So I'd like to thank the panel for the invitation to speak here today. So think about new workspaces. Physically changing workspaces can be a difficult process for any type of worker. You know, imagine being just an average desk worker and one day arriving to a new office surrounded by a new team of coworkers and someone else has unpacked your desk. You know, your files aren't organized, you can't figure out how to work your new printer, and you can't even find a pen. You know, this at best would elicit some dissatisfaction, but at worst delay progress on assignments, meetings, deadlines. For physicians, though, physically changing workspaces can be exponentially more detrimental, as these spaces can have a direct impact on patient care activity. Simulation, though, can be invaluable for this process. By actually putting healthcare workers in realistic patient care scenarios, we have a unique opportunity to analyze human system and technical performance. And not only does this process help us let the coworkers get more familiar and comfortable with their new workspace, but it also gives us a unique opportunity to preemptively identify any potential weaknesses in technologies and systems that may otherwise lay dormant until the facility actually opens. So in the next few slides, I want to share with you how simulation has been applied in this manner in a few different clinical workspaces, as well as some opportunities for further refinement. So one of the beginning applications of using simulation this way began with a group of emergency medicine physicians who wanted to see if using simulation, getting workers to actually participate in a simulation for a new clinical workspace was more valuable than the typical orientation to that space. And so this group had a small group of ED staff participate in just one simulation 4 days before this new space opened, and compared their preparedness reactions to those who participated in only the orientation. And they noted the latent safety threats that emerged. So from just this one simulation, again, 4 days before the opening, they were able to identify 18 latent safety threats that may have otherwise gone unacknowledged. So you'll see some themes popping up here, anywhere from just difficulty locating light switches to less than ideal placement of monitors, all the way to identification of communication systems that were just unusable. And impressively, in that just 4-day window before the space opened, they were able to correct most of these. More recently, we used simulation to test the readiness of 2 new trauma bays for ED and surgery staff. So we had them rotate through a series of multi-victim trauma scenarios in this new space. And not only did we want to see if we could identify any latent safety threats, but we also sought to examine if this process, these exercises, actually enhanced perceptions of worker readiness to work in the space, satisfaction, communication, et cetera. And from this series of simulations, we were able to identify significant improvements in all of these variables, with the exception of cardiac readiness, from before the simulations to after. And of note, these sims actually took place after the standard approaches. So they've already went through an orientation for the new space. We had them do a scavenger hunt in the new space so they get more familiar with the environment. So these data really suggest that simulation does in fact have enhanced value above and beyond what standard orientation approaches may offer. And of course, from this process, we were able to identify a number of latent safety threats. And you'll see that these trauma bays at this time were really lacking some crucial components that would have had a significant effect on patient safety if they wouldn't have been checked. So lights were literally striking team members in the head, resuscitation equipment was absent, some monitors were missing, and teams weren't really quite sure about the best paths to the OR from this new space. But because we put this in place quite a bit before the opening, again, we were able to fix these before patients arrived. Another group used simulation to test the readiness of their new space, but also used this as an opportunity to clarify roles and responsibilities among their new team members. So they put a series of individuals through numerous what they called mini simulations leading up to the opening of a new facility. And from this work, they were able to identify that their medication nurses were experiencing too much workload. So as you see in this figure right here, we have workload illustrated for each team member role, with values from 30 to 60, indicating really ideal workload, and values over 60 indicated overload, too much. And so from this process, from these series of simulations, these groups were really able to redefine and reorganize their protocols and their processes so that everyone had a more even distribution of workload. And again, from this process, they were able to identify a number of latent safety threats. And these are popping up in the same themes that we've seen before. So lack of equipment, some missing resources, some issues with medication, as well as personnel. But again, because they did this up to 3 months up to the opening of this facility, they were able to correct most of them. So more recently, we use simulation not necessarily to test the readiness of a new clinical space being built, but to evaluate the readiness of a space that's rarely, if ever, used, our decontamination suites. And the readiness and integrity of these spaces is really critical during outbreaks like Ebola. And for us at UT Southwestern in Dallas, Ebola was especially pertinent to us as the first few known cases of contamination occurred just across town. And so, like many other hospitals across the country, we immediately took action and began to stress test the hospital protocols and functionality of our spaces. And our approach, I think, was likely similar to many others, in which we had standardized patients, dusted them with an ultraviolet substance meant to simulate the Ebola virus, and presented them to the ED staff. And once there, the staff were instructed to engage in normal procedures like intubation, blood draws, dialysis, etc. And then after they doffed and degonned their equipment, we used a black light to scan them and see if there's any break-in protocol. And from this process, we identified a number of latent safety threats. In fact, we found 52. But you'll see that when we were broken down by themes, it wasn't really necessarily issues with PPE, but more staff understanding of just the protocols and adherence to those protocols. And just about a year ago, we had a new university hospital open up in our medical center. And we wanted to use simulation for these similar purposes for these new OR spaces. So we used what we called day-in-the-life simulations. So specifically, we randomly picked 5 surgeon teams to walk through 4 typical procedures within their specialty. And from this, we're able to note a number of latent safety threats, about 1 per simulation. And we also asked, after each scenario, we asked each participant to rate the extent to which they felt that they could operate at their highest level within the new space, as well as their confidence that their team members could operate at their highest level with this new space. And you'll see from first simulation to the next, there were some increases, with significant increases from that first sim to the next sim, but then it kind of really plateaued after that. And then we also wanted to take this one step further. So we wanted to really demonstrate the value of putting these physicians in practice and their teams through these series of simulations. And so what we did is we actually followed them into the OR after the hospital opened. So we had a trained observer go in and watch the first 2 cases of each of these surgeon teams who participated in the simulations and rate their teamwork. We also had an observer go in and watch 8 other surgeon teams that didn't participate in the simulations, who just walked in day 1 and started cutting. And from this, we're able to identify that those groups of surgeon teams who participated had significantly higher cooperation and situation awareness as rated by those observers, but no significant differences in problem solving and leadership, which you might expect. So we know that simulation is becoming a valuable asset, not only for research, but for performance improvement. And from this work, we know that simulation is a great tool for proactively identifying these latent safety threats, and that it's also reliably improving worker attitudes and readiness and confidence to work in these spaces, as well as team processes after they actually go there. So we do have some remaining questions to really further understand these processes, for whom it's most successful, for what type of space, what type of worker, et cetera. And really, we're going to be able to demonstrate the value of this by tying it, of course, to some more objective outcomes, cost savings, patient outcomes, patient responses. So for example, in one of our simulations, one of our standardized patients remarked something like, I'm really glad you are doing this now because this is a little chaotic and I would not be impressed if I were a real patient. So, really demonstrating that link, I think, will increase buy-in as well. But just with what we know so far, with some of this literature as well as others, we know that simulation used as this type of methodology is valuable and can help us mitigate and potentially prevent some of these negative effects from just walking in this new space. And then it should be an approach adopted by many hospitals when going through these changes. So again, I thank you for your time, and I'll take questions later, I believe.